Thanks for being patient with our audio-visual setup here. It took us a while. But, so my name's Anthony Spinnickie. I'm with the Atlantic Orthopedic Associates. Our office is in Whippany. This is our office manager, Amy Reisman. She's actually a native of Parsippany. On the way in, she was telling me where she grew up and her high school and all that, so she's a homegirl here. All right?
Homegrown.
All right, so thank you very much for inviting me. What I wanted to talk about today was hip arthritis, what to do for it, and also in particular a special type of hip replacement that we offer at Atlantic Orthopedic Associates that's different from the traditional hip replacement that's been done in this country for the last couple decades. Okay, so again, we're from Whippany, New Jersey, but we operate out of Morristown Hospital, right in Morristown, New Jersey. It's a 700-bed hospital. We're a level 1 trauma center, very good nurses, they're magnet-accredited nursing staff. And also recently, it was accredited by the American College of Surgeons as a center of excellence for joint replacements. So that's something we're very proud of to get that designation. Not many hospitals in the country have that. So, and as most of you know, Morristown's very historic. It was George Washington's headquarters twice during the Revolutionary War. Anyone know who this is here? This guy right here. Yes, Benedict Arnold, very good. The reason I bring him up is because he was actually tried in the courthouse in Morristown for a court-martial. For not really treason, it was improper war prizes, but that's where he was court-martialed, the traitor. So not many people know that. All right. So again, what we want to do today is treatment options for arthritis, and what is hip arthritis, and then we'll go into this what we call the anterior approach hip replacement. So what is arthritis? Well, arthritis is anything that's wrong with cartilage in a joint. In a joint, there are always two bones, and the two bones have to move, just like in a joint. In order to move smoothly and without pain, what we have is cartilage on each end of the bone. It's nice, shiny material that when it's wet, because the body makes a lubricant in the joint, they're very slippery, and it's like two pieces of wet ice that move on themselves. And that's why we can move our joints normally, painlessly, and very smoothly. And here's the hip. You see the hip, as we all know, is a ball and socket joint. You can see the ball is completely covered in this nice shiny cartilage, and so is the socket. And when the ball fits in the socket, you get nice motion that's smooth and painless. Now this is an x-ray of the hip, and you see between the ball and the socket, there's this nice space that's between here, and that's actually the cartilage. We don't see that on x-ray because it's mostly water, but when you have healthy cartilage, you have this nice joint space. Now with arthritis, for some reason, there's a problem with the cartilage. It could be because of previous trauma or injuries. It could be because of wear and tear, just from a long life of running or working out. And things like lupus or rheumatoid arthritis, these things can lead to the cartilage getting diseased and breaking down. And so what you have is no longer shiny, nice cartilage, but you have, you see bone on bone. That's why you get grinding, that's why you get stiffness, and that's why you get pain with arthritis. You'll see the difference on x-ray. Here, there's a nice space, this is a nice normal hip. Here you see that space is gone. Not only is it gone, but now the ball isn't a nice circle anymore. It's kind of flat, it's got like cysts in it, it's very white from all the grinding. So this is a picture of advanced arthritis. That's what it actually looks like on x-ray. So what can you do for this? So early on, you don't want to jump to anything like surgery early on. You want to do things that are less invasive first, right? That aren't going to interfere with your life. And so the best thing you could do is avoid the things that make it hurt the most. So if it's a lot of running, you stop running. If it's things like tennis or golf, maybe you don't do the full 18 holes, you just do 9 holes. And see if you can modify your activities enough that the hip doesn't hurt you anymore. Other thing you can do, which it is an option, but not always the best option, is to use a cane or a walker. That's going to relieve the pain, but then your activities are going to suffer, right? You can't do everything you want to do, and that's not really our goal. We want to get you back to being active and healthy and maintaining an active lifestyle. So you can take medication. All right? You can take any type of happy pills, the Advil, Aleve. And there's things you can buy in the drugstore now, the glucosamine and chondroitin sulfate. Everyone sells that now, any of the Rite Aids or even Costco's. And all that is shark cartilage, right? And then people believe that if you eat it or if you take it in, it'll eventually replenish your own cartilage. Now we haven't proven that yet in the science yet that actually works, but a lot of people swear by it. A lot of relatives, a lot of neighbors that take it and they say it really helps them, so it's worth a try. And there's all the over-the-counter stuff, Advil, Aleve, Bayer, that can really help you get on with the activities that you want to do. Physical therapy. The thought is that if you strengthen the muscles around the joint that has arthritis, the muscles will take on all the stress and the joint won't hurt you as much. So people go to physical therapy. Well, before we get into it anymore, okay, who here has knee or hip arthritis, if you feel like saying, or knows someone who does? All right, so a lot of people are offered injections, cortisone injections, or a lot of the Synvisc or the Orthovisc injections. And this is a good option too, because it's something that can be done quickly. It's either a same-day surgery or you can have it done in your doctor's office. And there's almost no risk because it's just like getting a shot, like a flu shot or something. But the problem is, if you have bone-on-bone arthritis, it's really not going to help you. That's a late stage, and it's only going to help you if you have cartilage to treat. If your cartilage is gone, you're running out of options. So really, the definitive treatment is to replace that joint. That's after you've done everything you possibly could. Now you have to go in, take that arthritic joint out, and we put in a mechanical joint or a hip replacement. All right, so the hip replacement. So what is it? So basically what we do is we take out the parts of the joint that aren't good anymore. We take out the diseased cartilage, or the bone that has the worn down cartilage, and we replace both sides. We put in a new ball with a stem that goes into your thigh bone, as well as a new socket. They're all mechanical, and as you see, they're modular. We put in a special piece of plastic that also becomes very slippery, just like your own cartilage, that allows you to move painlessly and smoothly again. This is the actual implant out of the body, obviously. So traditionally, most 99% of all hip replacements in this country are done through the back, or what we call the posterior approach. People are on their side in surgery. The incision is down the side of their thigh. But the problem with this surgery is that we have to cut a lot of muscles and tendons in order to get inside to the joint to do what we need to do. We split one of the muscles completely in half. Other thing we do is we have to cut a lot of tendons off of the bone so that when we peel them back, we peel all these back. Now we're looking at the joint, and we can put in an artificial joint replacement. But the problem is, by cutting all these muscles and tendons, we weaken the hip, all right? And the problem is, people can't do certain things. They have restrictions. How many people here either had or know someone who has had a hip replacement? All right, so I don't know if either for your own experience or from your friend's experience, there's certain things you can't do. Right? You can't flex past 90 degrees at your hips, so you can't sit in a low chair, you can't cross your legs. And the biggest thing that really bothers people is you have to wear a wedge between your legs at night, because that's to keep the ball from coming out. Because the big fear is dislocation. It's the ball coming out of the socket, like you see here. So to prevent that, you can't sit in a low chair, can't cross your legs, can't squat. But you get used to it, you modify your life, and eventually after 6 months you don't have to sleep with this anymore. And eventually years down the road you do well. You just get used to those restrictions. Another problem with the regular approach is you can't use X-ray. This is our X-ray machine. And you see this is the table where I'm going to talk about, but there are certain things that we look for on X-ray that we can't determine when you're on your side. And the one advantage to the back approach doesn't take as long. It takes about an hour. So you're in the OR for less, it's easier for the surgeon, but there's a lot of downsides. The muscles and tendons are cut, so you're weaker. There's a risk of dislocation, and so because of that, you have all those restrictions that we talked about. All right, so I want to talk about the approach that we offer at Atlantic Orthopedics, okay? And it's called the anterior approach. And anterior is just a scientific name for the front of the hip, not posterior like the back of the hip. And unlike the regular incision, our incision is in the front here. It's in the front of the hip, and the patient is lying on their back facing up. Okay, and we use a special table that we have at Morristown. This table allows us to put the leg in any position that we need to keep it in while we're preparing the hip for the hip replacement. And basically what we do is, instead of cutting muscles off of bones and tendons off of bones, we work between two muscles. There's a lot of muscles in the front of the thigh. We just spread them, not through one muscle, but between separate muscles through a natural plane in order to get into the hip joint. We use the same exact implants, so the same implants that you would have put through the back or put through the front. So people ask me a lot, do they last as long? And they last exactly as long because it's the same implants, the same science and technology. What are the advantages? Well, patients have less pain afterwards because we don't cut any muscle or tendon. All we do is spread them. Because the muscles and the tendon attachments are left like they're supposed to be, people are not as weak, and they have an enhanced recovery, so they're out of bed quicker, they get out of bed the same day. I'll show you videos of some of my patients where they're out the same day, and they're more likely to go home instead of going to a rehab facility, and they're discharged from the hospital a lot quicker, and they're more likely to walk without a cane or a walker sooner. And I'll show you a couple of examples. There's a very low dislocation rate, so the ball popping out of the socket, because it usually always pops out of the back because all the muscles and tendons that we cut off in the back. We don't do that here, so it stays where it's supposed to be. So the big advantage with that is you can do all of this. You can cross your legs, you can sit in a low chair, you can squat. You do not have to wear that. So really you have no restrictions afterwards. And unlike on your side, you're on your back. So we can get a really nice look at your pelvis. We can get a nice x-ray. And we can bring this machine under, there's all this space underneath. We bring it in and we can actually take a look at what's going on. We can measure all the angles that we need to measure to make sure we put all the implants in the perfect position, or as close as perfect as we can make it. That's just shots. Here's us in the operating room. And I just want to show you that your feet are in boots that we take out of the table, and what we do is we actually take your leg after we're done and we move it in all different directions, and we make sure the ball doesn't pop out. So when we leave, we know it's rock solid, stable, and it's not going to come out. All right, so here's a case example. This is a 72-year-old male, and the reason I put him in this presentation is because he had the regular hip replacement done the old way about a year and a half before. He wasn't happy with how long it took for him to recover. He didn't like his restrictions, and he heard about this method. So he came to me and we said, okay, we'll do it. And he was up hours after his surgery. Okay, so 72, and this is him the night of the surgery. So he actually walked a lot, and what I did was I asked him here to lift both legs up, and you can see he does one leg stances, and he puts all the weight on both legs at one time. We'll see that in a second here. And this I'm going to tell you, this is really good. I used to do it the old way as well, the posterior way, and you never see this, the day of. So here's he's going to put all of his weight on one leg. That's the side we operated on, and then everything on the other side. All right, so this gentleman, he owned his own business. Okay, so he went back to work 4 days later, right? Because he's his own boss, so he probably didn't have to do much, but still, he got out, he drove himself to work, did fine on the 4th day. On the 5th day, he came in for follow-up. So this is 5 days after the surgery, and you'll see how he's doing here. So he's walking with no devices, no walker, no cane. Little bit of a limp, but I think he's a superstar for 5 days after surgery.
Yes.
All right, so here's another example. This is a 66-year-old woman. She came in, hip arthritis, and she did great. We did the anterior hip on her. She walked that night. She went home 2 days later. I didn't have my camera the day of when she was in the hospital, but I did see her again 5 days later. This is 5 days after the surgery. So here I ask her again, could you put all your weight on each of the legs? And she's able to do it. That's the non-op side. Now this is the side we did surgery on. So you see a little unsteady, but for 5 days as a surgery, that's a very good result. She worked at a bank, or she did some type of job where she sat most of the day. It was a desk job, but still she went back in 2 weeks. So that's a big deal after a hip replacement. All right, so the question I get a lot is, why doesn't everyone do this then? Why doesn't everyone go through the front, do the anterior approach? And there's a couple answers why. It's a couple reasons. First of all, this is not a new approach by all means. This approach has been used since the 1800s, for other types of hip surgeries, traumas, that sort of thing. And my training is in trauma and fractures of the pelvis. That's why I'm familiar with this approach. I fixed a lot of fractures through that interval. But there was a guy in France in the 40s, his name was Robert Judet. He was a trauma surgeon, and he started doing these hip replacements through this approach. And he and his student, Emile Tournelle, also a Frenchman, they became the fathers of acetabular surgery or hip socket surgery. So for us, these guys are like our idols. They're like our Michael Jordans, So anyway, so these guys did it for decades in France, and it never really took off in this country because we used someone else's method. And there was a trauma surgeon in Southern California, his name was Joel Mata, who still practices. He went over there to learn how to fix pelvic fractures, and he saw Tournelle and Judet doing these anterior hips, and he's like, what are you doing? Why aren't you going through the back? And they're like, oh, we have great results this way, you'll see. He learned how to do it, and he came back to the United States, and he told all his buddies, he's like, we got to start doing this. It's amazing. And everyone was like, no, they were set in their old ways, and they were like, you can't do it, don't listen to the crazy Frenchman, this is the way to do it. And so he just started doing it on his own. And he did the first one in the United States in 1996, and since then he's done almost 2,000 of them, all with great results. And out of 2,000, only 3 have dislocated. So that's a really, really low percentage. And so, he taught his students and so on and so forth, and so our numbers are growing of who actually does it. But it's only been in this country for about 20 years, and that's how I learned. I was one of his students, and so now I teach my students, and hopefully as time goes on, more and more people will do it this way. So that's the main reason, is that most people don't know how to do it because it's been a well-kept secret for a while, and only now is it becoming more popular. The other problem is it takes longer than the normal hip replacement. It takes me about 2 hours, 2.5 hours. The normal hip replacement takes less than an hour. So if you're a surgeon who's got to make a living and all you do is hip replacements, you can't afford to do, instead of 4 or 6 in a couple hours, just 1 or 2 in a couple hours. So that's the second reason. It's not financially feasible for some surgeons. We're able to do it at Atlantic Orthopedics because we're mostly trauma practice. We work out of the ER, we do hip fractures, car accidents. This is something that we do because we enjoy it. We like to see the results. We're privileged with the knowledge of knowing how to do the anterior hip, so it's an obligation of ours. We feel that we get a lot of pleasure out of doing the anterior hip. So we do only 1 or 2 a week. The patients get our full attention. I go the night of. I walk the patients myself, as you saw in the video. So that's why we don't, financially it's not really a big deal for our practice. It's something that we do out of pleasure. The other reason is a lot of hospitals don't have that special table that I showed you. It's a very expensive table. It costs about $200,000. And a lot of hospitals, especially in this economy, can't afford that. We have it at Morristown because it's a trauma center, and we need that table to fix certain complex fractures of the pelvis. So we were lucky enough to have it, so we use it to do these hip replacements. So those are the 3 reasons. All right, so I'll sum up. I don't want to blab up here forever, but just to sum up, so the advantages of that anterior hip replacement is that we don't cut any muscles or tendons. So because of that, people have an enhanced recovery with less pain. They're walking quicker. They're walking without a cane quicker. They have no restrictions. They can sit in a low chair. They do not have to sleep with a pillow, as you saw. And the other thing is we can use x-ray on that special table, so we know we're putting the implants in perfect position. All right. So here's the last case we'll show. This is an 88-year-old male, okay? So good health, 88-year-old guy, active. He also had the hip replacement done the old way 3 years before. He went to a nursing home for 3 weeks, didn't do much for the first 10 days, and so he was not happy with his results. So he came and he asked us if we could do his anterior hip, and this is the day of the surgery. This is 4 hours later. So I asked him to flex his hip, and he's a little reluctant at first because he knows that's usually against the rules. The back way, you can't do it, the traditional way. So he flexes it a little bit, and he asks, can I go further? And usually that would be a no-no, but we say, of course, go ahead. And so that's pretty good 4 hours later. And you see in this picture here, he's bending at 90 degrees, right? He's past 90 degrees. Usually the therapist would come into the room and yell at me for doing that, but with this, there's no danger. You can do it. This is him walking in the hall. And again, an 88-year-old man, 4 hours after hip replacement. This is a great result. You'll see me, I ask him if he can also lift his leg up on both sides. So that's the operative side, that's the hip that we did. And now he's going to put all the weight on that new hip. That's pretty good there. I asked him, you want to go back to your room? And he's like, no, let's keep walking. All right, so in this gentleman, 88-year-old guy, we almost always expect for anyone over 70, 75 to usually go to a rehab facility or a nursing home for at least a little bit. He went home. He went home on the second day. He was walking with a cane. He was doing stairs with a cane the second day, and he went home. And this is him 5 days. This is 50, that's my fancy camera work, sorry. So pretty good. You see now walking with no cane, no walker, and he's waddling a little bit, which we expect, but for 5 days after surgery, that's great. All right, so that's one extreme. Now let me show you. This is a younger patient that we did. She's a 51-year-old nurse. Okay, now she got early arthritis because she had an anatomical problem with her hip, so it just wore out quicker. So she had early arthritis. This is her the day after surgery. So she's obviously a little younger than the other patients I showed you, so her recovery was amazing. Here she's getting out of bed by herself. She has a cane, but pay attention if she's actually using the cane or not. She's really just using it just for security. I asked her if she could lift both legs. And you see the cane is just dangling, she's not really using it. So she had a great result. So she's a nurse, full-time nurse, and she went back to work on day 16, so about 2 weeks afterwards. And that's huge for a nurse to go back that quickly. So, and that's it. In the bags, I have brochures. There's magnets and some business cards, some pens. On there is the address, the phone number. There's also a website. All right, on the website we have more patient videos, any information that you want. This lecture will be on the website eventually, so you can see your guys winning prizes. But any friend who's interested in this, you can refer them to the website. They can just follow. They can watch the video online. All right, do you have any questions?
How is the insurance with taking care of this way? I'm sure that there's more money involved. Mm-hmm. Are they on board with it, or?
So that's a very good question. So as far as the cost of the, the code for the procedure is exactly the same. So when we submit it to an insurance company, it's the same code as through the front. The insurance company pays less because you're in the hospital for less time. You're less likely to go to a rehab facility. Other thing is too, we take Medicare. We work with all private insurances. The cost is exactly the same. The only reason it might be more expensive is because it takes a little longer in the operating room. So instead of paying for 1 hour operating time, the insurance company pays for 2 hours of operating time. But they save big time as far as hospital stay and rehab. But when we go and we try to approve these surgeries, we just give them the normal code for hip replacement, so it's never denied.
All those people were on the slimmer side. What is the rate with us little fatties?
Well, I don't know why you put yourself in that category. That's not really true,
it's
trust me.
The truth, and the truth is the truth, but...
So, let me see if I can pull this up. I'll show you a picture here. This particular procedure is good for people who are a little on the heavier side, as you put it, because in everyone, no matter how large they are, the space between, let me just pull up the picture here, hold on. So what we worry about, obviously on the larger patients is the amount of fat, because between the skin and the muscle is the fat, and that's in this here. And usually, this looks like a perfect circle of a thigh, but that's not how usually people's thighs are. It's usually pretty thin in the front, and the back can be pretty large. So this is not a good representation or a cross-section. So this amount of fat in the front here is never more than 2 or 3 centimeters, never more than an inch or so. So we can actually do a hip replacement easier through the front on someone who's overweight. All right. Now, as far as recovery, you should still expect a better recovery because we're still not cutting muscle. You know, you will always have a better recovery through the front than through the back because the muscles are left attached. Okay. And as far as if you're overweight or you're obese, there's less fat in the front, and so it's easier to get into the hip. You know.
Good to know.
Yeah.
Any other questions?
Yes.
Yes, sir.
How often do people need 2 hips replaced?
Good question. It's common. Okay. As a matter of fact, this week we're doing a gentleman who has arthritis on both sides, and the question would be, should you do 2 at the same time? All right. So it totally depends on what state of health you're in. Now, with this procedure, it's easier. It's easier to do bilateral hips, as we put it, on both sides because you're laying down and you don't have to flip the patient. Usually they're on their side. You would have to do one, close it, flip them, and then start it again. Because you're laying on your back, you can do one and immediately go to the other side, so it's less OR time. And also because we're not cutting muscle, you know, it's easier to recover from just one, so you can imagine it's easier to recover from 2 at a time. But in order to do 2 at a time, you really have to be in tip-top shape as far as your health goes. And your doctor has to say, your primary care doctor has to say that you're okay, you're strong enough that you can get 2 at a time. You know.
Because you're talking, what, about 4 hours on the table?
Exactly, yeah, 4 hours. And you know, it's longer operation, so it's twice as much blood loss, twice as much stress to your heart and everything. So the recovery, as you see, is not that bad. So sometimes it's not hard to talk a patient to doing it twice, you know, because the recovery, you see, takes only a couple weeks and you go back and do the other one. The recovery is harder for 2, obviously. Thank you very much. Oh, one more question, sorry.
How many operations do you do a year?
So we do about 1 or 2 a week. It comes out to about 4 or 5 a month, so about 50 to 60 a year.
What is the lifespan of these hips, approximately?
So these hips that we're putting in now, we have no idea, right? Because these particular models have only been out for maybe about 5 years or so. But we can look at the other models that have been out for longer. They last about 20 years. And we know that the ones we're using now are better. You know, we're making changes based on the data we have from the old ones. So we hope they're going to last at least 20, 25 years. And it all depends on how active you are. Like anything mechanical, they'll wear the more you use them. So.
Can you also tell me the downsides? There's always downsides to things happening too?
That's a very good question. So the downside is it takes longer. Okay, so you're in the operating room for about twice the amount of time, right? The other thing is, because of the only other disadvantage I can really think of is the incision, where it is. It's in the front, so you can't really hide it. If you're gonna wear a bikini or something like that, it's in the front. but the other thing is, everyone, no matter how thin they are, when they sit down, they always have a little roll of tissue that kind of like folds here. So for the first week or so, we have to make sure we keep that area dry so it doesn't get wet and break down and have wound problems. And really, those are the only 2 downsides, you know. Yes, ma'am.
Wasn't there some recall with regard to the metal that was used, or?
Right, so if we go to, let me show you, I'll pull up a picture real quick. Very good questions today. Okay, so that recall had to do with what they call the bearing surface, or you know, every hip replacement has a ball and socket, and the ball and the socket can be made of different things. You know, there's plastic or there's metal sockets, and then the head can be made of plastic or ceramic. And so the recalls were on implants that had a metal head and a metal cup, so metal on metal, and it was made by a company J&J or DePuy. Thank God I never used metal on metal, and the company, just by chance, that I use is Stryker, not DePuy. So I fortunately have had no patients that had those recalled implants in. The other thing is I use all plastic, and the head I'll use either ceramic or metal, depending on what the patient wants.
Ceramic has a good record.
Yeah, ceramic is, the best bearing surface is a ceramic head and a ceramic cup. That has the best record. It lasts forever, basically. They cycle these for millions of cycles. They never wore. The problem is they squeak sometimes. About 5% of patients get this mechanical squeak. No, I'm serious. And it drives them crazy because they can't sneak up on anyone. You know, they wake up their spouses. And sometimes they want it replaced. You know, they'll go back to the operating room and have it replaced. Right.
If I knew it was gonna last until I was gone.
Well, but you know, they make the plastic so well right now. They cross-link it so well, make it so wearable that they last just as much as ceramic now. So I'll use a plastic liner and the head, depending on how old they are and what their goals are in life. We'll use either a metal head or a ceramic head. My pleasure.
Thank you.
Thank you very much, Dr. Spinnickie.